Hello, and welcome to the Common Thread, where we pull together the people, policies, and possibilities that shape health in real life. I'm Vaughn Rhodes, your host for today's conversation. Whether you're tuning in with coffee in hand between meetings or just needing a moment of substance in your day, I'm so glad you're here. If you would please place where you are listening or viewing us from in the chat. So I'd like for you to put your organization, your city, your state, your country. We are always looking to learn and see how we can make connections from all over the globe or nation or even just locally in North Carolina. So let's get right into it. Healthcare is advancing faster than ever. But here's the truth: innovation without equity can actually widen the gap. Precision health has the power to transform care, but only if systems, policies, and communities are woven into the design. Today, we're talking about how precision healthcare can move from research labs into real people's lives, especially in communities too often left behind. To help us explore this urgent and inspiring topic, I'm honored to welcome a leader who is pushing boundaries and setting the standard for innovation with equity. Malika Simmons is the Chief Operating Officer of the National Accelerator for Discovery and Precision Health. She is known for her visionary leadership, operational excellence, and her deep commitment to ensuring that the tools of tomorrow are accessible, ethical, and equitable today. Malika, we're so glad to have you. Please introduce yourself and share what your grounds work in precision health.
Hi, good morning. Hello to everyone. Thank you so much for having me. I am Malika, as in I like a Malika. It's a pleasure to be here with you all. So NADPH is the National Accelerator for Discovery and Precision Health. Precision health is customized health. It's health fit to the population at hand. And one of the things that actually the underlying thing that NADPH seeks to do is to make sure that people with lived experience are not just considered, but part of the fabric of our healthcare system, whether it's through access, whether it's through education or innovation, that people of various lived experiences not only have a seat at the table there, and they're not just making the dinner, right? They built the table, they built the house in which these decisions are being made. So it's very, very important to us that we continue not just a ground up, but a top down, ground up, and in the middle approach to healthcare access, and to addressing all of the social determinants of health. So social determinants of health being places where you live, where you go to school, what sort of healthcare access you have, what does your education look like, what are your healthcare supports? Because one of the things, and I'll turn it over to you in a second, but I really want to emphasize the thing that I think gets overlooked the most in the SDOH is the support systems. Because you say, oh, we'll
Right.
build a hospital, we'll do this, but what are the health support systems that people have to make sure that they can take care of themselves?
That's absolutely correct. I love how you brought that in. I was having a conversation last night talking about my work in health equity and why it's so important to me. And as some of you all know, I'm presently doing my doctoral. I'm a second year doctoral student, and I'm getting my degree in global health equity. And so the question that was placed to me is like, why is health equity so important to me? And why is it the direction of why is it so important to me? And for me, it's because I believe that, and when we talk about health equity, it segues directly into what you're talking about, is that what I'm seeing when it comes to health equity is that we're becoming more very systems and very apathetic in the way that we do health equity, if that makes sense. And
Mhm.
so my goal is to recapture that story, and
Right.
so recapture the why. So the caretakers, the structure, the support systems that are there, and understanding like, okay, so why is this person in this space? Not just the fact that, okay, let's include the conversation of the social determinants and the political determinants and the commercial and digital determinants, right? But what is the story behind that? And so when I hear you talk about precision health, to me that is the I guess the cream between the two Oreo cookies. if that makes
Okay.
sense. Right. Because it is integral to understanding not just about defining and meeting and making systems and organizations where they meet people's needs, but sometimes we're doing these things just to check off the box.
Yes, yes,
So does that make sense? And so
yeah,
when we're talking about health equity, what I'm seeing in terms of health organizations and health systems, that they're integrating and they're doing health equity, but they're doing it from the lens to be inclusive, to check off the box, not to truly see the individuals and that are dealing with these healthcare outcomes and issues that they're experiencing. And if you're doing it from the lens of precision health, then what you're doing is you are designing a system that is whole health,
I love that. Yeah,
opposed to just targeting the individual, because there are many factors in play that people go into when it comes to barriers.
yeah,
And also when we talk about health equity, is it really health equity or is it health barriers or health disparity
yeah.
that people are dealing with? So I'm loving this conversation that we'll be able to have. So that
Can
leads me right into that main most important question: what is precision health? Could you break that down for some?
Yeah, yes. And before I do, I want to tap on something you just said because I think it's really
Mm-hmm.
important around equity and
Mm-hmm.
what equity is, right? So, when we talk about disparity, if you break the word down, is not having parity. So, really, the parity part is actually more important. So, when we say equity, we get bent around and axle around making things equal and even,
Mm-hmm.
and that's not what's needed, right?
No.
So, we don't need everything to be equal. We need everyone to have equal access.
Access.
We need everyone to have equal chance at healthcare, but the approach to that may differ. And that's where
That's
the
right.
parity comes in, right? And so
Mm-hmm.
if I only need this much, or I only need this one thing, but someone over here needs far greater for us both to have good healthcare,
That's right.
then that's
Mm-hmm.
what's needed. And so I think a lot of the work that we do at NADPH is really, to your point, explaining to people that no, we're not trying to make it's not a kumbaya thing, it's not a check the box thing. We're not trying to make everybody happy all the time because that's not to be had. But what we are trying to do is make sure that there are not, as you said, additional barriers for people based on some characteristic that they may have been born with, or where they live, or how old they are, right? So thank you for bringing that part up because I think that gets missed too. And now to your question about what precision health is, it's an approach to healthcare that uses all of the characteristics of that individual to make healthcare decisions. And that might be your environmental, your lifestyle, your genetic factors, all of the different things that make you you, tailoring medicine and approaches and therapies to that particular profile. And I've been hearing about precision medicine for 25 years or so, and, maybe more for those who are staunchly in this field. Um, and there are some gains that have been made, but I think there is honestly an utter laziness on the part of some to not want to just group everyone together so that they can just make it easier. And that does a disservice to the individuals. It does a disservice to the
Absolutely.
data that comes from those individuals. You and I had a conversation a while back, and my lineage is Caribbean, right? So my the way my grandfather's family and on one side of my family and the way my other grandfather's family, on the other side of family, both would be considered black, but they have different ways of eating, different ways of
That's
worshiping,
right.
different ways of just interacting with the medical community and others. So if I ignore that in their healthcare, then I'm missing a big piece of the puzzle. And that's what precision health seeks to do. It seeks to look at the person as an individual and then make not necessarily changes, but may have approaches that address that individual's healthcare needs.
I love how you phrase that and how you painted that example, because I see that within my family. And you're right. When we were having this conversation, we were able to really dial into and see how in our own personal ancestral lineage, how this is so important. I like to say that people are not monolithic, but we try to use monolithic perspectives in how we actually approach the things that they need. And so, like, for example, in my family, I was raised Seventh day Adventist. And for the most part, many Adventists are vegetarian. So, I was vegetarian before this whole wave of everybody wanting to be vegan and, and a plant-based and all this stuff like this. It's nothing like being an 80s child and your mama tell you that you can't eat Oreos. you know, or certain candies or cookies. And, you're always the strange one when you go to school. And so, understanding that, when we would go to the doctor, and she was also very holistic in her approach, with certain things. She would not allow us to have certain medications. She would not allow us to use certain body washes and just certain things just in total. And like I said, this is way back in the 80s and stuff. So when we would go to the doctor, my mother was looked at like she was strange, or part of a cult or what have you. But those were just the lifestyles. And then also she comes from an indigenous background. So my mother is also Waccamaw Tuscarora Indian. So playing the Waccamaw Tuscarora Indian, how she was raised a very herbalist and holistic perspective, then integrating in her own religious perspectives, she was a little different, right? And she's walking in, she doesn't look, she presents like your typical Black woman, but her values and how she moved and her lifestyle was not monolithic. So when we talk about precision healthcare, that is why it's so important to understand the story, because that story helps you design things that are relevant and pertinent and not letting people feel like they're the odd duck out, and that they're the ones that are doing something different. Because so often when we talk about healthcare, we always put the onus on the individual to fix their issue. Does that make sense?
And I like how you frame that too, because so you're bringing up exactly what I just said. It could be your religion, it could be your culture, but those things need to be taken into consideration. And in precision healthcare, we seek to have patient engagement that asks those questions, right? Where that ask communities and patients to give that sort of information and collaborate with them to make decisions based on maybe their risk factors because they're of a certain population, or how do we deal with folks? So like in NADPH, we've had interactions with all sorts of communities all across the country, from Middle Eastern, North African to the Bhutanese community. There's small subsects, the Hmong community. There's small subsects of communities that approach healthcare much differently, and you can't just use a cookie cutter one fits all. There are some communities in which you can't bring up certain topics; they're taboo.
Right.
So how do you get women's health done if you have to have a female physician and you can only have certain conversations? I'll give you a good example. We are working with an indigenous population and talking about healthcare and some health research. And so one of the things, just to be clear, we uh, we don't speak for these communities, right? We just provide platforms and access so that they can come and we educate them on whatever it is that they need to know to make the best decisions for themselves. So when they come to us, for example, and maybe we're looking at, hey, we're seeing that there's a high um, cancer, diagnosis in our community. Well, if you're in a certain community where it's actually taboo to talk about fecal matter, like that's a taboo subject, how do you talk about doing a test, right, that can determine colon cancer in a community for which that is something you don't talk about? Now,
Right.
the prevailing medicine minds might just create a thing and they'll tell people they just got to sign up or they just got to give the data or they just have to. Whereas at NADPH, we're like, okay, how might we? Oh, one segue. I am a human-centered design strategist, so I'm a certified design thinking practitioner, and we make sure at NADPH all of the work that we do for policy, program, and products are human-centered design. They follow what's best for the user, how the user feels, user meaning the end user, the patient, patient-centered, how they feel about it. So the human-centered design question is how might we? How might we do a thing? Because when you say, can I do something, that's binary, right? Either you can or you.
Right.
So once you say, can I do something, somebody will come along and say, oh, you can't because there's no money, or oh, you can't
That's
because the
right.
communities won't let us, right? So instead, we say,
Or
how
you
might,
can with stipulations.
right? And stipulations are okay because it's good to know the playing field, but let's not shut it off. So when we
Right.
say how might we, it opens the aperture and we can explore solutions that are patient driven and not hospital slash healthcare driven.
I love that you said that because it is important that when we talk about building a table or having a seat at the table, it is about having that table, being in the structure of the design of the table, not
Absolutely.
not having a table and then me inviting you in, right?
Right. Right.
Because you've already decided the type of wood that you wanted to use for your table. You've already decided the circumference or the style of the table that you wanted. You've already decided that, where that table is going to look or all those things. And now you've invited me in. Whereas if you say, how might we create this table? Now I'm included in that conversation to say, I really need a table that fits at about a 4 feet height, because the people that we're going to be working with are going to be taller. And so
Yeah.
we want to make sure that they are included in that conversation. Or maybe if we source the table or the woods that we need from more of an ethical sourcing, that way it is not damaging our community. Because when we talk about health equity, we also need to be considerate that people of color in their communities are at the forefront of environment injustice,
Yes.
right?
Yes. Yes. Yes.
So, being ethical in how we source those products and the things that come along with it. So it is really about having that conversation, and getting together, and we build the table together, not inviting people to the table that we have already created.
Absolutely. And that's a very important part about the entire life cycle of decisions and decision making.
Mhm.
So, we've done research at NADPH, and a few years ago, we did some work that we published through with the Robert Wood Johnson Foundation, where we were looking at the involvement of persons with lived experience in the data life cycle for healthcare, right? And it would not surprise you that it was low on all the areas, but what also we looked at is the fact that a lot of times people are not necessarily looking at all of the stages, right? So we looked at,
Mhm.
are you including people with lived experience in the planning? What about the collecting of data? What about the
Collecting.
access to data, analyzing the data? Let me see. I have we have eight phases: interpreting, recommending, reporting, and disseminating. Like those are the eight gates that we see as necessary to have people involved. So to your point, if we were building a table, they needed to be at the planning stage, right? But if we're talking about all the way at the end where the dissemination, who the information comes from matters, right? So if you're going to disseminate data to a community, who's doing the dissemination? Who's going into these communities and talking to people? Who's reporting it out? Who's making recommendations? Because that matters, right? Who is interpreting the data? Because if I get some data, say I get data that has already had insights gathered or what have you, and someone other than my community has done the analysis, maybe they didn't take things into consideration that they should have, right? And so maybe I would have looked at it differently if had I had the raw data. So do I have access to the data? So all of these things kind of work with each other, but it's really, really important that we make sure that people with lived experience and people who are from the communities that we seek to help and from the communities that are being impacted, these community health workers, these patient navigators are included in the process and completely understand the data life cycle and the social determinants of health so that they can help communities to make better decisions for themselves.
Love how you brought that in, especially the data portion of it. And that's really important when we talk about interpreting data and analyzing data,
Mhm.
because without having the right person at the table in that terms of that conversation with that data, although a person may be an expert in their field in terms of data analysts, if you don't understand the context of one, how
Right,
that data was collected or
right.
who it was collected from, data can be interpreted many, many different ways, and it can be
Yes.
interpreted for whatever way that you find beneficial for yourself and not necessarily beneficial for the communities that you're trying to serve. So it's important that you have those who are actually part of the community. And so when you see something that may be atypical or typical, they're able to bring that story and that conversation into it to reset it and say, okay, yes, you're looking at 1 in 5 persons in our community may be diagnosed with said blah blah blah, but what else is there? Why is that made? Is that a positive? Is it a negative? What have you? Let's bring that conversation and make it a lot more siloed to understand and laser focus of what is happening, because that interpretation can lead you down the wrong block to
Exactly.
create the wrong type of program, right? It can lead you down the wrong block of different types of systems interventions that they really don't need if you're not having the right person interpreting the data in a proper contextualized type of way.
Correct, correct.
So when we talk about NADPH and in the reducing of health disparities, what are some ways that you all are implementing or leading out in terms of reducing health disparities?
Education is very powerful. People need to understand their healthcare. They need to understand the technologies in which their healthcare resides. So if I go to a doctor's setting, how are they? Am I able to get an appointment? And when I do get an appointment, how is the doctor treating me? If I get an appointment, am I more likely to come back to that doctor? Is it too far away? So as we see lately, it's been historically, but also lately, the closure of hospitals, right? So
Mhm.
people in rural situations were already at risk because they were far away. And now you don't really have to be rural for you
That's
to
right.
not have access to a
Absolutely.
hospital. So
Mhm.
basic healthcare information, like even preventative, especially preventative, actually, right? So if we're gonna, we shouldn't be closing hospitals, but it is what it is. We have to until we get to a situation where we can do something about it. What do we do with people who are in situations where there are not hospitals? Well, what about home health? What about telehealth? What sort of things can be made available to them? And also, what can we be telling them about their everyday health care, right? Their preventative health care so that they don't wind up in the hospital. Now, obviously, injury and an emergency aside, one of our director of community engagement, she is. Listen, well, I call her the roving reporter, okay? Because she is out there in the communities. Literally, she might be in a tree, and I am not even joking. Log rolling with the communities, like archery, doing whatever, baby showers, wherever the community is, that's where Tammy is. And so I think that's just brutally I can't understate how important it is to actually be shoulder to shoulder with people to understand what it is. Why? So if you, for example, if you make healthcare recommendations, like, remember the little the plate with the sections and everything, and they tell people
Yes, yes, yes.
the balanced meal. We did a survey a couple of
Shout out to Tammy Shepherd. She's
years.
watching us today.
Oh, yes, exactly. We did a survey, some work with the CDC a little while ago, when they talked about the balanced meal, right? And so
Mhm,
when you said about what about the why
mhm.
is really important because if you tell
It
people
is.
that they should do a thing, but you don't understand why they may or may not do it, then you're just putting
Mhm.
out edicts for no reason. You're just telling them to
That's
do
right.
it, right? So when we did this, we did some focus groups, we did some interviews. Shout out to all the qualitative researchers out there because that is my jam. Quant, y'all okay too, but I'm just saying. I love
My
qualitative.
girlfriend Shannon is a quality. She's doing her dissertation on qualitative data. So you and her would be like,
That's see, right here, right here. So we did interviews and focus groups, and we were asking people about this notion of a balanced meal, and they're like, "What the heck is that?" Right? So, what does the word balance mean? And so, what happens is the CDC or others who are putting out these surveys, they may do, they do cognitive testing, right? And they think that's enough. Cognitive testing just says that the person knows the word balanced. I know
that's
what
right.
balance means, but I don't know what it means in this context. So they're
Hmm.
missing the context. So I'm a Caribbean American, and I say balance is some jerk chicken and some roti. So what
Don't
do
make
you
us
think?
hungry this morning. Come on.
So what do you mean by balance? How much stuff is that the amount of food I have on my plate, or
Yes.
so just putting the question out there, and that's why surveys are also can be detrimental because they're static. They're in time. The person looked at a question you asked, had no field of reference, and made a decision on how to answer it. Whereas if I have an
Hmm.
interview, somebody can ask me that question, and I can fill them in and get better data. And so
Hmm.
I'm always pushing for as much as possible to contextualize data that we receive, right? So you have a free text box, and I don't get wonky into the whole data and all that stuff. But if you have a text box where somebody can write something freely, or if you have a yes or no, all of those
Mhm.
things matter as to how you interpret that data and how you make decisions after the fact. So we're conscious about that. But to the point of what I was saying in terms of being in the community, you got to be asking people, you got to be asking the right questions. You have to be non-offensive when you're doing it. You cannot be paternalistic or patriarchal or telling them what they should and should not be doing. You should be asking
Come
them
on.
what they need and then
Yes.
helping them, co-creating solutions with them and not for them.
Absolutely. And the other part of that is that you have to be intentional in your community engagement. And
Yes.
what I mean by that is that first of all, you got to have somebody who's excited about being around people. So
That
let's start there,
part.
okay?
Yes, yes.
Because sometimes we're hiring people who claim that they love community engagement, and the time that they get invited to go to the hog wrestle, they're like, I don't want to go. You know what I'm saying?
They love the data that they get from it, but they
They
don't
love
love.
the data that they get from it, right? You know,
Right,
I'm not that hog wrestle girl, so let me
right,
just let you know.
right.
But somebody else is like, yeah, let me go down the block and do the hog wrestle and the hog ski week, and well, not ski week, so I'm an AKA, so we're not gonna
Right.
do it. We ain't gonna do those ski, but the hog call.
Yes, yes,
So
yes.
and someone may be like, yeah, let me get on out there and do that suey, and they have fun with it, and they see that joy and they see that excitement because when you're getting invited into certain spaces, you need to have just as much joy and excitement as the
Yes.
community that you are there to collect data from, or that you are there to represent, or that you asking for some information from. And it starts with just going to the small things and getting plugged in, and people getting to know who you are, and like, okay, all right, she's showing up and they know who they are. For Tammy, the community that she is, people know who she is within that community. So it's not some one-off kind of thing when she goes
Right.
in. And then people are just kind of like, well, who is that? Kind of thing. They seem a little standoffish, and they just come in, bring their tables, put their tablecloth down, and put up the information that I'm from said organization, and
Right.
here, take my things, and just sit there.
And we,
No getting up and getting from behind that table, especially when we go to communities.
yes.
That's like a pet peeve of mine. You invite people to these tabling events, and they stay there. They
Mhm.
sit right there at that table the whole time. They don't get up and get out and go explore what's at other people's tables, or just go walk around and pick up and observe and see how things are, and let someone ask you or say, hey, can you show me how to get to et cetera, et cetera, complimenting people on the food or
Yes,
drinks or what have you, and just give that hospitality. Take the hospitality with you. You know what I'm saying?
yes, I
Start
do.
expecting people to always welcome you. Why don't you be the welcoming
Why
person?
don't you be the welcoming? And I see Tammy just said she was in Rocky Mount yesterday. I told you,
Mhm.
listen, she was in California, Rocky Mount, Maryland. You never know where Tammy's going. Tammy is like, where in the world is Carmen Sandiego? We're gonna get her a hat. So we can figure out where she is. And it's so funny. We were also, Tammy and I were talking about the interesting piece. So we both have North Carolina connections. So shout out to NC, because when you were just talking about the tribal community, my family is from Meherrin tribe in North Carolina, and not I'm in Virginia now, and depending on where you go, not too many people even know who the Meherrin is, but um,
Mhm.
it's just so funny that that's part of community. Like there's so many, like I said, multi-layered. We are very intersectional people, right? There's lots of things that
Yes,
that we do and that we participate in. And so being in all those spaces and places matters. And that's how
it
we get
does.
actual data, real data, not
That's
something
right.
that somebody, here, can you do this survey? And they check off the box. Um, I'll tell you, one time we did a community health fair and in Philadelphia. And so, like I said,
Mhm.
we're in the inner city, we're in rural, we're everywhere, right? So we were in Philadelphia, and it just so happened, and it wasn't for an aging population, but for some reason, this particular day, we had a lot of elderly people come to our table. And one of the volunteers who,
That's my population. Now, let me tell you, I love some elders. Damn, I,
yes, yes.
I, I love the elders.
Oh, right. Just a pure joy. Just have you
Mhm.
just cracking up. Like, listen, I gotta get work done. I can't sit here talking to you, Miss May.
Right. Yes.
Um, and so when we're at the table, and the volunteer was telling us that you should making suggestions on how we do things differently. Like
Mhm.
for elderly population to come and fill out a paper, they ain't finna do that. They did not want to do that.
Forget it.
What they did want to do was talk to our volunteer. So what she wound up having to do
Mhm.
is sit down with each person and ask it like an interview, and they answered all the questions. But when she
For
gave them
real.
the paper, they didn't answer.
Mm. They don't want to
So
be on with it.
they
Mhm.
didn't want to be bothered. But as soon as
Because it's for them, it's just another type of thing. Like when they have to go to another form they have to fill out. And it's
Mhm.
also, it's just another way for them to not be seen.
Yes.
Because when you are having conversations with your elders, that is a recording time. They're about connection. So they want to you to hear them. So
Yes.
not just write down and record what it is
They
that they
wanted
have
the
to say.
conversation.
They
And
want to
so
have a conversation. That's
that
right.
should inform your
Mm-hmm.
your logistic policy as it relates to grassroots operations, right? So that means that guess what? You can't have one or even maybe two people at a table. Maybe you need three people at a table because
That's
somebody needs
right.
to interact. Somebody got to be the person, the crowd barker. Come on over to our table. Somebody got
That's
to be
right.
the person that actually sits with them and has conversations because sometimes now you might have even digital now. In these days, we can have an iPad. Some people are going to fill out that iPad, some people are not. So do you have
Mhm.
multiple ways to fill out the survey? Have it on an iPad, have a recorder, ask them, can you record their conversation? And also be able to write it down on paper. So thinking through what are the logistics of getting the information that you need and not in an extractive way. So another thing that we're very considerate of is that we're not always taking from communities. What can we do to give, right? And so, like when we did our focus groups, um, we had this one young lady, one of our qualitative researchers. She is phenomenal. We call her the link queen. And shout out to Latanya Bynum. I don't know if she's on, but
Well, I know Latanya. Yes.
the
Hmm.
link queen. When I say that we had data equity coalition folks, we had public health leaders on the call. She was like, "Oh, you're a public health leader in Waxahachie, Tennessee, blah blah blah. Here's the link to the CDC that you need. Oh, you're over here. Here's what you need." So she was giving them stuff. So some of the
Latanya is a walking, talking Google.
yes, when people came back and gave us like our responses, first of all, we had a 98 point something percent rate. Who has
Who does that,
on the
right?
survey?
Especially, come
They
on now.
they
You
returned,
struggle.
and
It's struggle monster with surveys. You might get 68% as
we
far as the
had
people put
90
send it
stuff.
something back.
Almost every single person filled out the evaluation survey. But what they said in the free text was, I got so much from this. So it wasn't so much that they were, yes, we got the data we needed from them and asking the right questions, but they also got something from it. And that's how you have to
Mhm.
interact with all of, not just the community, the medical community, the on the ground community, individuals and people in the system. We need to be giving to one another, not just extracting, and especially not just being extractive in our communities because they're tired of it. They're tired of just
They
being
really are,
the
and
one.
that's about also. So when we talk about NADPH, what I'm hearing you say is that you're very intentional about how you hire the particular people that need to do certain jobs within your community. It has to be paired correctly with those going into those spaces, because if not, that disjointed is how you're not going to get a 98%. Because so when we are looking at the things that we do in public health, one of the things I want to challenge my public health colleagues in doing is being very thoughtful, intentional about who are you assigning or tasking or
Mhm.
asking to do certain things, certain tasks.
Absolutely.
Are you catering the task to the personality and characteristic and the skill set of the person that you're asking them to do? Because they might be more of an administrative person and they may be best in that space and allow them to thrive in that space. But then they may be more of somebody else may be more of a community centered person, and you got them doing admin jobs, and now they feel stifled and they're not being their best, not bringing the best of themselves to the positioning that
Right.
you're having, which you're not. So now you're not getting great results back,
Yeah.
in the work that you're seeking to do, or the survey or whatever it is that you're
Yes.
trying to run, because you've got people disjointed in different spaces. You got the right people, but you got to plug into the wrong space.
Right. And you also have to realize like some things are, there are things that can be learned, right? And
Right.
so you have to make sure that the things that you want the person to do, they have, if they don't have the skill set, that you teach it to them.
That's right. Hmm.
And one of the challenges in the public health field is funds, right? So
That's
sometimes you
right.
only got two people, right?
Right.
So you only have two people. You can't afford to bring on somebody else. And then if you work off of volunteers, sometimes and I think we think about volunteers the wrong way in our
Oh,
profit
I
spaces.
was just about to go there, but I'm waiting. Yeah.
Volunteers are not like, just go get me some
They're not
coffee
your
or
interns.
right, go sit at the table. No, no, I will tell you this. So, Dr. Carlisle has done a tremendous job. He is our chairman and chief scientific officer at NADPH, has done a tremendous job of attraction marketing in our organization, right? So every single person who has touched NADPH, we have a volunteer for first policy, right? And so, for the most part, every single person has volunteered their expertise. And when I say volunteered, I don't mean they stood at a table. It's nothing wrong with standing at a table, but I'm talking about we have our chief AI officer, our cloud technician, people who have all sorts of expertise volunteer their time, effort, energy, and heart into the organization. And so, I challenge nonprofits to look at volunteers a little bit differently. It's not just for the so-called low paid or a little bit or give them a gift card. That's not what volunteer is. And volunteer is to give of yourself. So if you got someone who is a Nobel Prize winner and you know him, he can volunteer. Right.
Mhm,
He can
mhm.
volunteer to bring his skill set, to bring his knowledge, to bring his colleagues to the forefront. So thinking differently, and again, I think Dr. Carlisle has done just a tremendous job of being able to bring like-minded, like-hearted individuals into the organization. And then we all roll up our sleeves when it comes to doing any of the work that needs to be done, but we're giving from the place where we overflow, right? And
Yeah.
so
Mhm.
that's the key to, I think, having a very successful nonprofit in terms of making sure that all the doors and windows are taken care of.
Yes.
But,
Mhm.
right? But the
Yeah,
light,
and learning how to properly collaborate and barter. So if you're not in a space of with, as we know, right now in the terms of the climate of public health, it
yes.
funds is looking a little funny, right?
Yeah. Right, right.
I don't want you to do nothing strange for a little
Would you
money, but it's
change?
but money is funny right about
Right.
now, in our space, God bless us. But so that means that you got to think differently,
Yes.
right? And so how can we collaborate and barter? If we do this, if we provide system analyzation for you, then you will do admin or you'll send your people out to collect the information and data. We know
Yes.
that your people are just on it. They
Mm.
got connections inside the community. They know everybody. They know the community champions. They know blah, blah, blah. But they just don't have the system analyzation and administration part, on it, right? So collaborate and barter together. And that way, and then make sure that you give each person credit,
Yes.
because we good for collecting data and putting our names at the top.
That's
And
right.
so we can get said grant or said whatever it is, and leaving off the other part of the party and not allowing them to receive as much shine. It's important when we are in these spaces, everybody needs to deserve to receive their piece of the pie and to
Yes.
be seen in that same way. No organization needs to be highlighted higher than the other when you are collaborating
Yes.
together.
And I'm glad
Like
you
that
said that
makes more
about
sense.
the piece of the pie and collaboration, because some of the things that we've done in the past and continue to do is to make sure, for example, students, people are, I think when you get interns, when you mention interns, right? But when you have
Mhm.
interns, we need to be a little bit less authoritative when it comes to having students work with us. These are some brilliant minds, and they
Yes, they
just
are.
need the platform to do great things. Yes, you're going to want to put some guardrails around, your particular way you do things in your organization, but you need to let them go because they have the
Yes.
energy, they have the ideas, and we have had great success with working with students in the past. The other thing is, I think we don't understand quite the impact that visibility has, right?
Mhm.
And so putting, for example, when we were working on an NIH grant a couple years ago, we were very, very specific that we published work and we included HBCUs as authors so that they are then more likely to be able to get their own grants. Because you can come in with someone as a partner or come under someone, but the more you're published, and some new students don't understand the power of publishing, right? But
That's right.
publish it.
That's right. That's right.
Get their names on presentations, get their names on national conferences, get their names
That's
on
right.
peer-reviewed work, so that when they go to apply for their own grants, they can say, they can cite themselves, they can show where they've done work before. And that is so powerful in helping them move, so they're not always looking to someone else or another organization to bring them on, that they can lead the work that is important to them and to their communities. So that is one thing that
Absolutely.
is very
And
important.
why that's also important is because oftentimes, especially when we're talking about our interns, first of all, we need to reframe how we look at how we have conversations about interns,
Mhm.
because interns are not unpaid labor.
Right.
We need to be thoughtful about how we do that. But if you're in a position that you're not able to pay them, then teach them the skill sets that they need. And as you said, invite them into doing publishing, because what I've been hearing from many of the interns is that they once they get their degrees and they get into the community, they no longer want to go into public health. And that's because that they were just regulated, go collect this data and create this dashboard.
Right.
Go do this, go do that, just kind of the busy work that we don't want to do. But
Right.
it's important to include them into significant opportunities such as publishing and all that. It's not even about, they don't have to have the first name, because we know that that is the main author. But
Yeah,
having their name on that, what that does is it provides little incentives for them to keep on going in the space of
absolutely.
public health. And so,
Absolutely.
because they are our tomorrow. So if we don't help provide little nuggets for them to pick up, they will not want to continue in this space.
And
And
like you
it
said,
takes a lot.
take them out of, again, when you're small and you're lean and you're trying to do stuff there, you may not have, the ability to make these sorts of decisions, but just keeping cognizant that you should be considering it, right? When you
Mhm.
can is important. So for example, if you have an intern that you're working with, because you're supposed to be teaching them something, they're supposed to be learning something, right? So if you have an intern, that person should be able to, I don't know, maybe they're running the Excel sheets where you're putting in the data, maybe they're doing something on SPSS, but also maybe take them with you, that particular intern, take them with you to the health fair so they can have a conversation with Miss May. Because there's something about connecting the data that you see on paper and digitally to
Mhm.
an actual living person who needs, some sort of healthcare or healthcare support. Years ago, I started my career in clinical research, and so
Mhm.
I. I remember the first time I saw a commercial for one of the drugs that I had worked on, that I had patients taking those
Mhm.
drugs, right? To when they were in the study. And then I actually saw the commercial. I'm like, wow, I worked on that. And so it was an interesting thing to be tied to something in that way, right?
Mhm.
That you might not, I didn't have to be a doctor, a nurse to have some sort of impact in the medical community, because now people could take this medication and it was something that I personally worked on. And so having that sort of connection and helping interns and others, I think anyone in the organization, I think we all should take a step away from the number sometimes and actually see the people, and vice versa. If you're always into the people, you also need to see, like for example, from a policy standpoint,
Mhm.
take some of those people with you when you well, for me, go to the Hill because I'm always on Capitol Hill, but to your local legislators. One of the things that we have done is we help our communities to be their own advocates. So we had
Mhm.
a series of town halls, maternal health town halls. And in order to register, you put in your name and your email, but you also put in your zip code. And then we explain to them when they're on the call, we ask for their zip code because we want to know who their congressional representative is. And so we can write letters on behalf of communities when we know whose community showed up. So we can go to Senator so and so and Congressman this, that, and the other and say, listen, your constituents care about this particular issue. They showed up for our town hall. And so we're helping them to do the work, but we're also letting them know that it's possible. Because you know how many people didn't know that they could write letters to their congresspeople? You know how people didn't know that they could actually have meetings with their congresspeople? So helping them understand that they don't have to be submissive and are passive in their own healthcare. They can actually advocate for it, and here's a way to do it is really important as well. So bringing everybody in on the work is important.
And that's led it to my question was going to be, how does NADPH co-design with communities and steward data ethically? You're definitely answering that in that space. And one of the other things that I love about the example that you use is the fact that when we talk about politics. And an example that I can give you is some years ago when we were, facing COVID, we were out in the community. We would go and sit up and we would sit down and talk with people in our community. We actually walked the community and find out that, people needed to be vaccinated, help them get vaccinations, what have you. But beyond that, I remember we were doing an outreach at a particular place, and I was able to sit there and talk with those who were in there that were either apprehensive
Mm-hmm.
or getting vaccinated, and hearing the stories that came along with that conversation. Now what you're able to do is take that conversation that you just had, and now you're understanding the barriers that people are having. Now you're understanding, making that connection of how that political determinant of health is either preventing them from
Yes.
having the access to services that they need, or creating even more barriers is what's going on, because that story is telling you that she is a grandmother that's taking care of 5 children, and 2 of them have special needs, and they're in, some type of um, food desert, or I think they now it's a new term is food apartheid,
Mm-hmm.
space, and all the other factors that's going on. And so if she's scared to have this child vaccinated because now she's feeling like, okay, that's just another thing I got to figure out. Now what if this one child gets sick? Now everybody's getting sick, and so I don't know what this thing is looking like, and how it's the medicine and the history behind it. So you're able to sit and listen and hear people's stories and their understanding, and now bring it all together. Now take that and inform it back to your lobbyists and those that are working, and say, okay, this is what your community is saying.
Mm-hmm.
Or what's even better, invite her, to come tell the story.
Yeah,
So, so it's not a secondhand type of thing. And
exactly.
that way, it is a firsthand conversation. They're able to see, meet, and put all those things together and understand, okay, now we understand why we need to create said policy, or advocate for this particular statute, or get this particular bill passed in this particular way. But
Right.
what happens is oftentimes we leave that out, and it's important that we do that. When you talk about data integration, right now, some of the big conversations that people are really, really having is AI.
Mm-hmm.
And so how that works in genomics. So how does NADPH integrate and have that conversation around AI and genomics, and utilizing that type of emerging software and technology to guide what it is that you all are doing?
Yeah. So we have a phenomenal team, and that goes back to what I was saying before about we have people coming from all walks of life and who are, renowned in their fields in terms of the work that they do, including artificial intelligence and machine learning. One of the things that we provided is a way to get into the field of AI. We kind of call ourselves sometimes the AI whisperers, right? Because people just
Mhm.
don't understand what is AI, what does it do, how does it impact me, how can I use it, that sort of thing. So we want to continue to have people asking that question. One of the things that we did is we worked with an HBCU to bring in one of their faculty members. He had an idea, and it starts with the ideas. People, that's what I meant about the staff and the this was at an HBCU, but it could have been anywhere where they have ideas, but they don't have resources, right?
Mhm.
So he's like, I want to do something in terms of working with women and diabetes, and how, like, to study that, to look more closely, specifically Black women and diabetes. So I'm like, great. All right, so we have an idea. We started with an idea, but there's lots of things that have to happen in order for you to conduct research, especially you conduct research using some sort of AI component. So what we did is took his idea, we brought him into our forums. We have these calls that are ongoing, where we bring in people who are interested in conducting some sort of research, right? And it just depends on the topic. But for this case, he wanted to talk about diabetes. So we had one of our partners at Temple University. He came in with his statistician, and he came in with his data analyst and talked about what sorts of data is available. They also provided the actual cohort data from a diabetes cohort at Temple University. So you have actual patient data that you can use. So this one university now had access to data, right? So that's one thing. Then we said, okay, well, he has to get IRB approval to be able to conduct this. And he hadn't gone through the process before. So our team worked with him to work with his IRB so that they can get the approval to run the research. And then he's like, okay, now that I know, now I have the data, I have the IRB approval, I have the idea, but I don't know how to do this stuff in AI. So we had our AI and our cloud architect work with him to create something inside of an AI testbed, a portal where you can go in and manipulate data and run different analyses, do some predictive analytics. And that's about as far as I'm gonna go because I'm not a bebop booper, as I lovingly call our tech team. But I'm just letting you know that this person was able to go from I have an idea to a presentation at our national conference, right? So where else does that happen where you have someone in the community that is like, I'm interested in health, but I don't really know. And we surrounded him with the resources he needed to go from an idea to a published concept. And so that's the sort of way that we work with communities. And we've done similar research collaboratively with data equity coalitions. We've done it with public health leaders and others. It takes a village.
It does.
And so you got a great idea. You're an intern that you want to be a doctor one day. Come on in. Come on in. And we make, as Dr. Carlisle calls, stone soup. You get a little bit, you bring a little bit, you bring a little bit, and we come out with something on the other end that is actionable, right? That you can actually take something. And now this gentleman can take that, and now he's got research that's published, or he's got concepts that are published. He can go somewhere else and get that funded for research. So we're not doing anything by accident. It's all very interesting.
Yeah, and that is so important. And I love that you brought up IRB. So those who are in public health, the importance of having a good IRB, and knowing how that works. And I'm going to take your term, bebop booper. I'm not a bebop booper, but I'm a proud Black nerd. All blurs.
Blurred. There you go. There you go.
I am a proud blurred. So I love that terminology. As we are rounding about to the end, because you and I can sit here forever, and just totally ignore everybody, all the rest of the 40 some odd people in here. We get each other. Where have you been? And so one of the things that I did want to also ask you is what policy or pavement layers or partnerships like Medicaid and value-based care or HBCUs and MSIs are critical to scaling pilots into a sustainable practice?
So that's such a hard question, just because of the climate that we find ourselves in, right?
You can be delicate.
Yes, it's so. Ooh, Fawn, we need some more time. So the policies that exist still, the ones that are remnants left on paper, right? We don't know where they're going. And so what NADPH has been doing is we're still advocating, right? So a couple of times already, we haven't had the meetings, but we've been trying to get to the MAHA, the Make America Healthy Again caucus, to get to people who are pulling strings within policy. But there's big P policy and there's small P policy, right?
This is true.
So if you can't move the levers of government at the big P policy for whatever reason, and we all know what the reasons are that we're experiencing right now, what would you do at more local levels, right? Either the state level or even your county and township levels. What are the policies that exist? Dr. Uche Blackstock I spoke.
I love her writing.
She's phenomenal. So I met her last year at CBC. So I was speaking on policy and education in AI, and she was presenting her book, Legacy. If y'all don't have it, you need to get it.
Please get it. Let's give her and her sister and her mother a plug right now.
Oh my gosh. Yes. Yes. So,
Yes.
and so just as a tease, the book is called Legacy because she's a legacy student at Harvard. Her and her sister, her twin sister, they both were students, as was their mother, which is obviously a rare thing in the Black community, let alone Black women, the legacy. So she talks about that and talks about a whole bunch of other things. But one of the things that she said on her panel, because right after mine, I went and sat and waited and
Me
waited
too.
for hers.
Mhm.
One of the things she said at her panel was she talked about the notion of policy violence and how the things that are the edicts that are put out, the rules, regulations, and policies that are put out in the ether, how they impact our communities and our people. And the fact that we not only need to be aware of them, but we have to find the means and modes to address them in our everyday lives. So I thought it was just fantastic hearing from her, and it just reconfirmed the notion that yes, we have to work at policies, not just at the top level, but also we have to work at policies at the community level. What are the rules and regulations that make it so that you can or can't get the medication that you need, that you only can have, our healthcare, our health insurance, like, oh, you only get 3 visits when you have such and such need. Well, maybe I need 4, maybe I need a second opinion, maybe I need a
Mhm.
specialist, right? So
Mhm.
understanding what are the rules, and that comes from, some of them come from CMS, because the other thing about the rules at CMS, regardless of where we're going now, which I don't really know, but even the current rules at CMS are triggered by compensation, right? So
Right.
if the
That's right.
doctor that you're
Mhm.
going to is not going to be compensated for a particular procedure through Medicare or Medicaid, then maybe they're not going to offer it,
That's
right?
right.
So you have to be
Mhm.
aware of that. So those are the policy implications of the things that are happening at the high level that we need to be aware of. And that's the sort of thing that NADPH works to make sure our communities know about.
And that's so important because what I'm hearing you say is that we need to understand that policy is scalable. And so what that means is, maybe it is not your role as your organization to tackle the big P.
Mhm.
It is being a part of a coalition that is attacking the big P,
Right.
but it is more important for you to take the lens of what's happened in your local, and not just in your local, but just in your organization. Because there are policies and procedures within your organization that are systemic, that either are a barrier or accessible or provide access for the people that in the population that you're serving. So where is that? Are you looking at how you all are doing business and how you are serving your community? And are there policies within your organization that may pose to be a challenge for the population that you're serving, right? So
Mhm.
start looking there. So when we talk of policy, I also want to challenge people to not always look at policy from the big P perspective. Look at it from the scalability of what is happening in
Yes.
your ecosystem,
Yes.
what is happening in the organization that you are working at. You yourself, as to the point that you make it, you may not be able to be the one to make that policy change. For example, I work at a county health and human services. So the policy decisions that are made through us are made through commissioners, through the state,
Right.
through all that, right? So,
Right.
but what I can do is that because of the work that I do, I can inform my manager about what I'm seeing when I'm going into the community because of said policy. And
Yes.
now she has the power to advocate and say, look, this is what's happening when this particular team is going out into the community. These are the challenges or the wins. It's not always just about challenges. These are the wins that our
Yes.
community has experienced and seen when they're doing said thing. And so how can we duplicate the win in other
Mhm.
areas? And so, but you got to look at it. Like I said, it's got to be scalable. And I think it's the old proverb of how do you eat an elephant? One bite at a
One
time,
bite at a time.
right?
Exactly.
The elephant is the big policy.
Yes.
That's what that is. But if we look at it from a scalable view, then that means that it's one organism. Is this county health and human services doing something over here? It is this federally federal was it FQAC, federally
FQHC.
qualified healthcare
Mm.
this center that's doing something over here, and also understanding where you all sit within your ability of power.
Yes.
So certain times, it may not be, are you connecting with the right organization?
Yeah.
It may not be the local health department's lift that they can carry certain things because of the policy and that is connected, or the things that they are connected to. Maybe it might be a university within your area that you might need to pair with, or like I said, a FQHC, or not an NGO or something else in the area that can help you do the things that you are doing to implement things that are going to be beneficial to our community. Girl, we at 11 o'clock.
Yeah.
Look at there.
Yeah. And the
And we
last thing,
still got some people hanging on.
yeah, the last thing I'll say is you mentioned the ecosystem. It's very, very important to think about all the spaces and places where we need to be showing up. NADPH has a program called STAIRS, which is our Student AI Research Success Program, where we are bringing people in across different areas of innovation, including aerospace, including, all the innovation. Because if we think about workforce, if we are better able to bring home money to our communities, if we are in the spaces and places where decisions are being made, that has a domino effect on our healthcare, on our health.
Absolutely. That's something that's very important to me in terms of when we talk about health equity and just public health, that we help people understand that it's a whole health situation and it's a whole industry, multi-sector,
Multiple
multi-industry,
industries.
multi-organizational.
That's right.
My son, shout out to him. I love him to death. He's a freshman at Winston-Salem State University. And I say that for a reason, because Winston-Salem has learned how to partner with NASCAR. And that traditionally is not a space that you see a lot of
Absolutely.
people of color that are in NASCAR.
Right.
And Winston-Salem State is a pioneer in terms of health sciences and medicine in that space. So building that partnership with NASCAR is going to be so beneficial to help them understand how to do business. So we got to think outside the box.
Yes.
And how we partner and go to that space that we traditionally wouldn't partner with. So I'm going to let you have the final say of what you want to leave us with, what you want to challenge us to do, so we can be better tomorrow. And no, we can be good today and better tomorrow.
Absolutely. I think, one, to keep your head up, right? So this is a very trying time for many in many different places, and we're feeling it from all different angles. But we've been here before. We maybe not in our lifetime, but we've been here before. And as a society, as humans, we have to continue to lift each other up. And so why are we doing it? Remember your why. Remember why you're doing it and who you're doing it for, and reach out. You can't do anything and everything by yourself. I'm going to put I'm putting my email in the chat. So please, reach out to me anytime. You can go to our website. We're making some changes to the website to help people understand how they can participate in our activities and initiatives better. But we got to do these things together.
We do. I thank you so much for joining us. This recording will be available for those after the fact. If you go to our New Henry County YouTube channel, we will have it there. Also, NADPH will also have accessibility, so they will be posting it in their platforms. So we appreciate you for joining us for our September's, or rather our August, the common thread, because it's so important, that we learn to integrate and collaborate together, and look forward to our next Common Thread webinar next month in September. And we appreciate you. I hope you all have a wonderful Labor Day weekend. Go celebrate, go enjoy yourself, be safe, be secure, and just enjoy all that you're doing. Thank you so much, Malika. I love you for joining for me. Girl, I just feel like I just met my twin sister. Like we was just, we talk the same talk. We just, yeah.
Absolutely. It's been a pleasure. Thank you all. Thank you all for joining.
Yes. Have a great afternoon. Talk with you all soon.